get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host. And my next guest has a background as a CPA, having worked in various industries, including as a controller for a Blue Cross Blue Shield health plan and as a CFO for a third party. She has a passion for following the money and solving complex problems. We are thrilled to have her here with us today. Welcome to the big show, Marilyn Bartlett. Welcome.
Thank you, Ray. It's great to be here.
Oh, awesome. Thanks for joining us. So, our paths crossed, as mine do with many folks at one of the many conferences that I attend. Feels like I'm on a plane a lot. And you had a really interesting story. And, what's great about you is you're really coming at this from a finance perspective. And the folks that tune into Broken Healthcare, it's your everyday person all the way on up to folks that are responsible for benefits like HR people and finance people and CFOs, that all the people that you're comfortable speaking with. And it's tough when you have a conversation with these folks as a benefits broker or an advisor. I think their guard goes up immediately and they're very suspect. And they're used to doing things in a certain way. They finance professionals particularly tend to be creatures of habit. And so I'm very curious as to your journey and where it all started and when this kind of came on your radar, because I'm sure you didn't go to school to be a CPA or an accountant thinking, I'm going to have something to do with a major shift in the way a company or an organization spends money on healthcare.
You're absolutely right. After I got my CPA, I started working in industry, and I learned early on as a controller or a finance person, you have to follow the money. You've got to make sure everything ticks and ties and your debits and credits are in line. But I took a position as a controller at Blue Cross Blue Shield, Montana. And I was there for about 7 years. And through that time, I was in the guts of the financials. You could see the amount of money coming in, the amount of money going out. You could see the different investments. You learned an awful lot. And it was my first introduction to how many players there are and how many middlemen in this, whole field. And
Do tell, Marilyn.
yeah, I know.
There are middlemen?
Yeah, I know. I was absolutely surprised. All the middlemen, and I consider TPAs and insurance carriers middlemen. They're not payers in my mind. It's the employers, the employees, the consumers, the taxpayers. That's how all the money gets in the system. And then it goes through a lot of different middlemen, all taking their cut. So I was really surprised at that. I left Blue Cross Blue Shield and I went to work for a regional third-party administrator for self-funded plans, for employer self-funded plans. And as a CFO there, I think I had direct contact with employers, direct contact with different consultants, all trying to work through this picture. And when you're sitting in the finance seat, you do see the world a little bit differently. You see the money flows and things can be pretty black and white. So I was about ready to retire, actually, and I left that position, but was recruited by the state of Montana to take over the state employee health plan as it was on the verge of bankruptcy. They had just come off a year of losing 28 million, and yeah, it was horrible. And the actuaries showed a report in January of 2015 showing that the plan would be at minus 9 million in reserves if it didn't turn around.
Wow.
And everybody was upset. Legislature was upset. The executive branch was upset. The employees were upset.
Well, so I guess everything is relative. So those sound like big numbers, and it sounds like people were upset, so they were meaningful numbers. But just to put it into perspective, like as far as the overall budget, what percentage of the budget are we talking about?
Well, that's a really good point, and I can't remember, to be honest with you, on that. I
No
can't.
worries.
But it was a $200 million plan.
Wow.
Yeah.
Okay. Yeah.
So,
So
yeah, yeah.
we're not talking about, a mere bag of
No,
shells.
no, it was $200 million. So, knowing what I knew about how to follow the money, I jumped in
Mm.
and did many things. The biggest of which received national publicity, was that I I fired the PBM, the consultant, the TPA. I terminated extra wellness programs, those types of things.
How dare you,
I
Marilyn?
know.
I am sure that some of the higher ups lost good golf buddies because
They did lose golf buddies, they lost good friends. And because you have a legislature
right.
and you have a lot of lobbying money going in from the hospital association, from the insurance carriers,
Yeah.
PBMs, yeah, and consultants. But our main thing we did was implement reference-based pricing. So no longer were we going to pay hospitals and providers a discount off a charge master.
Mm.
We were going to pay Medicare Plus. And so, being an accountant, I studied the Medicare cost setting. I studied the Medicare cost reports for all the hospitals and their financial statements. So that's kind of what I brought to the table.
How did you come to that, though? Because so for our audience that might not be in the know, Medicare or reference-based pricing, as you said, uses a Medicare price as a reference point, right? And then typically they reimburse some multiple of Medicare, but it's almost always, and to be frank, it's always lower than the retail discounted price of the insurance carrier, and everything goes according to the charge master if we're talking about hospitals. And there are many different prices based on the same CPT code, so they kind of have at it, and they charge it at will, and they don't share this with the patients, with the employees, with the employers. They simply have a license to charge. And so this is your purview, your antenna went up and you said, hey, we could do better. But going from a fully insured plan or a self-funded plan using Blue Cross Blue Shield with, I'm guessing an independent TPA is what you're referring to at the time, to reference-based pricing is a bold move.
Mm-hmm.
And so how did RBP first come on your radar, and what was I'm sure you didn't just blindly do it. What was your due diligence process like?
When I was working at the TPA, there was one of our account manager salespersons who really spent time with me explaining to me the discount off charge master. An accountant doesn't get that. We just like
Mm.
to do cost plus. And so my focus was cost plus. And
Mm.
she helped me understand that that was possible. So that's when I started studying MedPAC and realizing that they set the inpatient and outpatient PPS, which is prospective payment system rates, to be fairly close to cost. And in reading the MedPAC reports, I saw that the relatively efficient hospitals were able to make a 1 or 2% profit on that Medicare rate. The other hospitals, the median was around a -8%, and the not-for-profit hospitals were -13%, and the for-profit hospitals were a little bit higher. And that stayed consistent year after year.
Mm.
So when I studied the MedPAC rate setting method, I realized,
And I'm sorry, what is MedPAC exactly?
MedPAC is the advisory board to Congress on Medicare. And they
Mm.
make a recommendation to Congress about the Medicare rates. So there are plenty of economists and accountants behind doing this and studying all the Medicare cost reports that come in. So that's when I started studying those. And
Mm.
I realized that they are trying to set relative costs, and they're different for every hospital. Medicare rates are adjusted for wage mix, geography, risk, outlier payments. So I kind of, accountants like that. We like cost plus. We can
Mm,
follow that easier. So that was what I brought to the table when I was interviewed was, why don't you consider just shaking this up? Why do a secret discount off an unknown charge master that can change? So we actually called it transparent pricing
mm,
because we wanted contracts with every single hospital so there'd be no balance billing. We didn't
mm.
want that disruption. So that's kind of what brought it out.
Yeah. Well, how did that work for you? Because I'm sure what you're describing is a situation in which I'm going to a hospital or a healthcare system, and the hospital or healthcare system, let's face it, they're not like, delicatessens in New York City where I'm from, where there's one on every corner. They pretty much have a captive market, and they're used to billing what they want. And then here comes little old Marilyn, and she says, well, I appreciate what you're doing, but just one thing I'd like, and that's a direct contract that spells out exactly what you can charge. How did that go over with those folks?
Well, it was interesting. It was a roller coaster. I was fortunate in that we did an RFP and only one TPA would do what we wanted. And that was Allegiance Benefit Systems out of Missoula, Montana. And they had been studying this method for quite a while. And they had a lot of data. So I worked diligently with Allegiance, who had relationships with the hospitals. We contracted with them and we were at every single table together. So my role was more understanding the financial condition of that hospital and simple things. If the hospital would come back and say, you can't do that to us because you're the state and we're losing 40% on Medicaid, I
Mm,
could go back to their records, their financial records, and be able to come back and say, you are losing 18%, not 40%. You're losing 18% on Medicaid, but it's only 9% of your payer mix. So that's a
mm.
different thing. If 9% of your total payer mix you're losing 18% on, is different than if 80% you were losing 40% on. So I was
Sure.
able to bring those facts. I mean, I'm getting really nerdy here, so I apologize to our
No,
audience.
no, I love we love this stuff. Some of us geek out on the numbers. I'm one of them. And look, the beauty of a podcast is if the audience gets bored, they could
Yes.
simply go and listen to something. But you keep going because I love what you're saying. So this is awesome. So you actually were able to go back to them with empirical
Yeah.
evidence and data. It's not like you just picked something out of the sky, right?
Yeah.
You went back to them and you said, okay, here are the numbers. And yeah, it depends on how you frame it, but you're not quite
You're
losing
not
as much as
quite
you're making
losing as
out.
much. And I had a great budget director, Dan Villa, and my supervisor from Department of Administration, Sheila Hogan, were real leaders on this effort too. So we all had
Mm,
each other's back, and it was interesting because we had very strong Republican legislature and a very strong Democratic administration. And so we were needed to show that we were negotiating separate contracts. We weren't putting in price caps or price fixing. But on the other hand, we were able to get the union on our side that because the budget director was able to work with the legislature, that if we could get the cost down, there could be pay raises again.
mm,
So it was a lot of moving parts, and 87% of our Montana spend was with 11 hospitals. So that's where we hit first. And we repriced claims as a percentage of Medicare. We determined a range we'd like everyone to get to that we would have savings. And we found two hospitals that had high quality numbers, all services, and were in that range. So we immediately contracted with them and held them out as our efficient hospitals. And could everyone else become efficient?
mm. Wow.
That's good messaging.
Yeah, it's good messaging, and it also inspires a free market and competition, which I think is
Yeah.
what you want.
Yeah.
And so you're not dictating to them that they must charge X, Y, or Z. You're simply saying if you want our business,
Mm-hmm.
here are the guardrails. And
Mm-hmm.
I think that's fair. So, but to help me understand, and I'm sorry if I'm getting too granular, but how exactly was the contract worded? Was it a specific flat percentage of Medicare? Was it did you have a schedule of all the CPT codes, and was there a fixed price per CPT code? How do you work that out? Because I'm sure that that was some of the pushback, right? How are we going to do
Yeah.
this, right?
Mm-hmm.
So
Yeah.
how exactly did you get it done?
Well, every hospital can bill Medicare.
Hmm.
So we didn't really need to change their processes.
Right.
And so they sent their claims. I had them, or we did, we sent them to an independent Medicare repricer,
Hmm.
an independent party.
Yep.
I would never send it to the TPA to reprice.
Sounds like you have trust issues, Marilyn.
Oh, I really do. That comes from being an accountant. We don't trust anybody.
Well, you know what? But hey, I think there's a valuable lesson there to be learned, right? We pay our professionals, our accountants, our attorneys to really be skeptics on our behalf.
Mhm.
And I don't think there's anything wrong with saying, okay, I trust you, but I'd like to verify.
Yes, trust but
Right?
verify. I'll use that.
Yeah.
I'll use that. But
Yeah.
the claim would go to a repricer that was very skilled at repricing Medicare claims and including outliers, using that hospital specific rates. Um, and then once it was repriced, it would go to the TPA, where the TPA would do their work of looking at medical necessity, looking at was it in line with the SPD, summary plan description.
Yep.
And then whatever the contract was, they would mark it up by that percent. So if we were paying 200% of Medicare, whatever the Medicare rate was, they just multiply it by two, and that's what would be paid.
So that's impressive because you didn't just simply say, we're going to pay you Medicare rates, right?
Mm-mm.
That wouldn't have flown.
No.
And you also didn't say, you're not losing as much as you said, and we're gonna pay you some small multiple of Medicare. You're paying them two times what
Mhm.
they're getting from Medicare. And if that's the case, they should be able to turn a profit on that business.
Yeah, when you look at it, we had inpatient coming in averaging probably around 220 to 230. Outpatient to begin with was we pulled down. I mean, one facility was at 611%,
Wow.
and we were able to pull those down to around 240 to 250. And then professional, most of them got a bump. We went to 160, but blended, it ran around 200%
Right.
for those three areas. And the interesting thing is it stayed right at that because the contracts were written that annual increase would be the Medicare increase, the lower of the Medicare rate increase or CPI met. So that's how we implemented it, and it worked. It went fine.
How was the reception by the employees that were using the plan? Did you have people threatening to go postal and take out their entire department? Did you have people, like burning things in the street and rioting? Was it chaos, or how was it received?
Well, I'm glad you brought that up because being an accountant, a nerdy accountant, kind of managing employees, not my specialty.
Right.
So, what happened was immediately employees were furious because they didn't get a rate increase that year. And the reason given was the health plan was out of control. So, fortunately, through Sheila Hogan and Dan Villa and the governor's office and the union leadership, we were able to work together for let's do this together.
Mm.
And we hired a consulting firm, a media firm, to do videos for us. And we called
Mm.
it transparent pricing. And we presented these videos and information to employees on what we were doing. And the interesting thing in the end, most employees don't even know what happened because it was they didn't even know. They just continued going to their doctor. They maybe had lower out of pocket, but they didn't have any rate increases since I think our last one was 2016. So the state and the employees had no rate increases, and services were expanded. We had on-site health centers already. We just expanded some services. So they had a lot of benefit, I think.
So normally what happens with RBP is the biggest friction point is the access to physicians, to hospitals, et cetera. An employee will be used to walking in with a Blue Cross Blue Shield logo on their card, and now all of a sudden there's no logo, and they're dealing with the receptionist or whoever's doing intake on patients, and this poor kid looks at the card and says, "We don't take your insurance," and that's when all hell breaks loose. So was that part of the issue? Were they going from a plan that had a big logo on their card, and all of a sudden now you do this transition, it's RBP, and that logo is gone? Or was there some multi-plan network or other network that was there?
When we made the change, Cigna was our TPA, and then we contracted with Allegiance, and we uh, we put in our summary plan document that any provider that was not in network, we would pay a PBME. This is a term we developed called
Okay.
procedure-based maximum expense. Good, huh?
I
And
like that. How dare you add another acronym to the insurance jargon? Oh my God, my head's going to explode. Okay, PBMA. Got
and
it.
it meant that we would pay that facility the price that we would pay a similar facility in geography, patient mix, whatever. So, for instance, Great Falls, Montana, there are 2 hospitals there. One didn't sign right away. So we were reimbursing them what we would pay for in Helena, which is maybe 80 miles away, or the community, the hospital in Great Falls. So we were continuing to do that. And we had to let employees know they could be balance billed. And there was anger there, but the union really helped us. The union leadership, we did mailers, we published the phone numbers, emails of the board members and the officers. And there was a general campaign. And after 6 weeks, that facility did sign on.
Oh, they saw the light.
Yeah. Yeah, we knew it was a horrible, horrible risk, but the worst thing that could happen is it would go back to what it was.
This episode of Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com today. Yeah, right. So you knew that was the worst case scenario, and so you had a contingency plan. The contingency plan is, if it doesn't work, we'll go back
to the way it was. And Blue Cross Blue Shield was right there at the door and wanted it, and
sure.
Lobbying totally against it. So that was interesting, but no, it was good. And through the time, the reserves built up to be way beyond the maximum that was needed. So over the time, the legislature was able to get $52 million back by doing an employer premium.
Stop the press. Hold on. Time out. The actuary said you were going to lose $9 million.
Mm-hmm.
You ended up with a $52 million surplus.
Well, actually, what we ended up in, he said in 2017 we'd be at minus 9 million. We had 112 million to the good.
Holy crap.
And that was because of a lot of things. It was mainly the reference-based pricing, but we changed to transparent pass-through pharmacy.
Right.
and we saved 23% there. We got rid of the extra wellness programs, which were 5.5 million, without a single complaint from an employee because they weren't using them.
Right.
We got
Are you
rid
are
of
you
a lot of
familiar with Al
things.
Lewis? Do you know Al Lewis?
Yeah.
So Al is incredible guy. He was a guest on the show, Harvard trained attorney, wrote, was the godfather along with, I think, a little bit of help from Marty McCary. Dr. Marty McCary wrote the Prevent Consent. If you're
Yes.
not sure what that is, go to our website, Broken Healthcare Podcast, and you could download a link. And that's something that anyone should be armed with if you travel into the ER. But Al was one of the first and most vocal opponents of quote unquote wellness programs, because what many of them, I'm going to say the majority of them, I don't want to throw the baby out with the bathwater and say they're all, garbage, but the premise was this will save your organization money. And Al, I think, has a standing $1 million offer for anyone who could show him a wellness program that actually delivers savings to the organization. So he put his money where his mouth is, and he's a former Jeopardy contestant, like lost to the grandmaster of all time. Anyway, that's enough about Al.
That's a wonderful, wonderful story. I didn't
Yeah.
I've used his. I mean, I've advocated for it. I am so proud. Yeah, they don't save money. And what we did was incorporate any type of wellness more into our on-site health centers with health coaches.
Right.
And that seemed to be a little more effective. But what happened then, we had the 112 million, and we had more money than the Montana General Fund. And it was a heavy fire season in 2017.
Marilyn,
So
did you get a raise?
no, I didn't. But I got to retire.
Oh my God! That's my next calling. I'm going to be. You know how there are sports agents. I'm going to be agents for business professionals. That is unacceptable. You saved 112 million. They didn't give you a dollar.
Get a raise?
Oh my God!
No, I think no, we didn't. But we then would lend the general fund money. But being an accountant, I made sure we got the statutory interest rate on those funds. And
I'm sure you did.
Yeah.
Wow.
And it was great. But over the years, the plan kept getting overfunded because these contracts were keeping everything at 200% of Medicare.
Wow.
And the funding was building. So over the years, the legislature passed bills that would give employer their holiday, and they were able to, in essence, pull 52 million back in.
Wow.
And it should go there. It's taxpayer money. It should go to where it's needed.
Yeah. And that's important. I'm glad you said that, because right now, with the introduction of the CAA, which wasn't just introduced back at the end of 2020, went into effect, I think 2021. Don't hold it against me if I have the dates wrong. But, the recent passage of the Consolidated Appropriations Act has employers now on the hook in the same way that they were with respect to their role as a fiduciary and spending plan dollars, the same way that they're beholden to their fiduciary obligations for plan assets of a 401k or, any type of vehicle like that. And so it is important that employers listening understand that they have a responsibility here, particularly if employees are contributing to the premiums and the costs of their health care. And so that should be a given, I think, right? Every employer should know that, hey, this is like table stakes. We have to make sure that our plan dollars are spent appropriately. But if you look at the other flipping side of this thing, with that kind of savings, okay, it's a $200 million plan, but run poorly, slated to bleed millions of dollars in losses, and run well, you generated a treasure trove that you were able to return to the taxpayers. For crying out loud.
And we brought it right down to $170 million plan.
Wow. That's crazy.
And it's just taking money out of the system and getting it back to the employees and the taxpayers.
Right. Yeah. And who could have a problem with that
You
other
can.
than the golf buddies?
Oh, I'm so glad you brought that up. Yeah, you're absolutely right. The golf buddies.
Well, listen, I hate to shine a light on it, right? But with that kind of money at stake, you could
Yeah.
imagine, those courtside tickets to the games, that money comes from somewhere. And when there's that much money at stake, the perks kind of flow.
Yeah.
And it's unfortunate, but it's the way the game is played. I'm sorry.
Mhm.
And
It
so
is.
having you on the job though, Marilyn, really you helped tremendously. You helped your organization, you helped the union members, you helped all of the employees, union or non-union, who were participating in that plan. And you're just doing your job.
Yeah,
Right.
I frequently say that. I just did my job. I was hired to turn it around, and I'm a finance person. Fortunately, on my staff, I had a nurse, I had enrollment people that are much better at that job. Don't
Mm,
ever put me on the clinical side. I know nothing about clinical, but
right.
I know I don't know anything. And then I tightened up a lot of the administration too to be pretty, lax. When you brought up Al Lewis's card, one of the things I'm finding interesting is when you go to a doctor's office or to a hospital and you have that little magnetic signature pad and they
Yep.
ask you to sign. I asked if I could see what I was signing.
Mm-hmm.
I wanted to see that document, and it really threw the staff off. And I had to wait a couple weeks, and then I had one sent to me. It's interesting to read what you're signing. Some of those are saying that if I don't pay within 30 days, this gets turned over to collection agency. And so it's kind of fun to say, what am I signing?
You bet. Well, that's a credit to you. And if you read his book, I think the second book
Yeah,
that he wrote, The Price We Pay by
yeah,
Marty McGarry, he
it's
talks
good.
about helping out a friend of his in the ER, and they shove like a tablet under his nose, and he's like, no, print it out,
Good,
and we're going to mark it up. And folks, you have the ability to do that. So, going back to Al Lewis and his company Quizify, and he's part of the Think 360 group, brilliant, brilliant guy. Actually taught economics at Harvard, so he's pretty good with math. He actually developed something called Prevent Consent, and if you go to the ER, you find yourself there, and they shove a consent under your nose that they want you to sign. There are two consents. One says you authorize them to treat you. You have to sign that one if you want to be treated. But the other one says you're financially responsible. You do not have to sign that, and they must treat you under federal law, EMTALA, Emergency Medical Treatment and Active Labor Law. And so be aware of that. And you can't just simply refuse to sign it, though. That won't hold up in a court of law. You have to write in specific language. And again, if you go to brokenhealthcarepodcast.com, you could click on the link that'll take you over to Al's site, and you'll get the actual language that you write in. And basically, what it says is you agree to pay reasonable and customary charges up to 2 times the amount of Medicare, and that's the magic language. Because if you say you want the best price of their best customer, well, you're some schmuck off the street, to use Al's words, right? So why is that? That's not going to hold up in court, and you can't simply refuse to sign it because that won't hold up in court. But if you sign off saying you agree to pay 2 times the amount of Medicare, that most definitely will hold up in court, and it most often will save you a boatload of angst and put you into financial trouble. So I'm glad you brought it up.
Well,
But
I'm glad you explained it. I learned a lot in that. Thank you for sharing that, Ray. That's
well, I'm here to please, Marilyn.
and educate.
Doing my best here, doing my best. So that is phenomenal. And well, what did you do for your next trick?
Oh, the next trick. Um, I went to the insurance commissioner's office just for a few months to work on some PBM proposed legislation. And then I decided I was going to retire.
Uh-huh.
That didn't work really well. I ended up taking a position with the National Academy for State Health Policy, and I now support states. I developed the hospital cost tool using Medicare cost reports, working with Rice University and Mathematica, developed this hospital cost tool using the Medicare cost reports that you can go in and you can see all those metrics that I used when I negotiated to see how the hospital truly is doing. And you know what's interesting? This year, and it'll come out mid-February, the new version 4 of the tool. I thought I'd make it 1 year and I'd truly retired. Now we're on our 4th revision. And we've put in what the hospital's drug costs are compared to the charges.
Oh, wow.
And it is astonishing because I kept hearing hospitals say, well, what's really making our costs go up are drugs. So I thought, well, I better figure that out because they have 340B. So I wanted to really know. So we've got some new things in it. We've moved it to Tableau. It'll be coming out. And then I have contracts with law firms they support employers access to their data. That employers many times, and I don't know in your position if you do in the consulting realm, getting all of the claims data. And by all of the claims data, I mean every single little bit of it. We also ask for the 835 transaction set, which is what the TPA paid the provider, so that we can catch spread pricing in medical. We also look at egregious contract terms. So that has put me in the seat of learning a lot more about what employers face, what consultants face when they're negotiating this. And I know you've seen it, but one of the things your employers, the FAQ that came out from Department of Labor, I believe last week, offering clarity on the CAA that you had mentioned. It's tough. It's good of what an employer has a right to have.
It should be. And we've gotten tremendous pushback from insurance carriers and still do, despite the passage of the CAA. They're fighting tooth and nail to keep that behind closed doors, to keep your information, which is rightfully yours, ladies and gentlemen. They're keeping that away. Now, why would you think they don't want you to see that information?
I know.
Right? It's crazy, but you absolutely have a right to it. And you just need to be partnered with the right advisors who are partnered with the right law firms who can write the right nasty letter to get you the information that you rightfully deserve and need to manage this expense. Because all that we're talking about, Marilyn kind of started out saying she likes to follow the money. That's what she does. But you can't follow the money if they're hiding the information from you. If the IRS came in and they said they needed to audit your books and you said you can't have our books, I'm sure there'd be some pretty heavy penalties involved.
There would be. There would be.
So you need to have data in order to do the job. And the trouble is PBMs are spread pricing. Hospitals are spread pricing. TPAs, there are plenty of bad actors out there who have their hand in the till, and on and on and on and on and on. You can imagine $200 million is a big number, right? And there's a lot of room for hiding things.
Oh, there is.
With that type of a healthcare budget. And so you bet that there are plenty of people with their hands in the till until Marilyn comes along and says, you know what, let's just take a look at this. And amazing what you accomplished when you did.
Oh, and I'm proud of what we did. We did it as a team. We all had different skills, and it was great. And I've been fortunate to now work quite a bit with patient rights advocate and power to the patients advocacy groups. And that's more on the federal level. And we've been advocating for federal policy, specifically the Braun-Sanders bill, Senate Bill 3548, which very clearly would be in law that employers have rights to the 835 file. They have rights to everything. They determine what third parties can get their data, not the TPA. So we've been working on that. We've been working a lot on proposed improvements to the hospital price transparency files and regulation and the tick files to be able to do a little bit more comparison. And one of the things that's interesting, two of us have focused heavily on the federal employee health benefit plan, which is the same as any employer health plan, except it happens to be fully insured.
So when I hear fully insured, I think to myself, full retail plus, plus, plus.
Plus,
It,
plus.
it's just, it is no way to manage any budget. You just, you're the foxes guarding the hen house, baby.
Oh, it absolutely is. And to think that, and I can understand how that came about because it was in the 60s and 70s before self-funded really got it out
Sure.
there. And by the time all that's put in law, it's just a big machine that moves forward. But to be taxpayers to be paying for a fully insured plan and to help a specific funding line for contingency fund
Yep.
is beyond my comprehension. So I've been having fun following the money and reading audit reports there. So that's my life now.
That's crazy. Listen, I was literally on the phone this morning, today, before we got on, with a controller for an HVAC supply company. And they, not a big plan. They have 50 odd people on plan. They're spending like 1.2 million a year. So their average is over $20,000 per employee per year. And they're spending like 1,500 per month for a single, 3,000 for a family. And think about that. When people when you slow the music down, you pump the brakes. And my insurance career started with Aflac, and Aflac, we used to have teams and we would go out and we would write business together. And it's not uncommon for any insurance company to have multiple agents. And when you're paid on a commission basis, you split commissions. And as a manager, I used to chuckle because people used to always come to me and argue about their split, whether it's 50% or 60%. And I'm like, you're asking the wrong question, right? You have to do the math. And if I tell you it's 10%, but you're going to earn $2,000 for a day's work, are you going to say no? You're not going to say no. Most people wouldn't. So you really have to drill down and figure out what the numbers mean. And without knowing what your baseline is, you're dead stick. You have no control, right? So this guy is telling me that they're spending $20,000 to $40,000 per employee per year on healthcare, and I'm like, well, what could you buy for $20,000 to $40,000? And might there be a better way to appropriate those funds? It's a very simple question, but the reason, Marilyn, that people are hesitant, it's one four-letter word that starts with F, and it's fear.
Yeah.
Right? Fear. People are afraid of the unknown, and they love their Blue Cross Blue Shield, United Healthcare, Cigna, et cetera, et cetera. But when you are a forensic accountant who drills into the numbers and you uncover what you uncovered, you follow the money, beautiful things happen for the organization, beautiful things happen for the participants, and good on you. One last question I have for you is, I often run into employers that their excuse is, this is all done through collective bargaining. We have no control. The union is involved, and it's not something that we can even touch with a 10-foot pole. Did you run into any such resistance? Because you mentioned that you had unions involved.
That's a really good question. Again, we had one major union. Over 60% of the employees were in the public employee union. And I think what happened is that the Sheila Hogan, director of administration, and Dan Villa, budget director, and the governor Bullock had really good relationships with the union leadership.
Yeah.
And so bringing the union leadership in right up front. I couldn't have done that. I wouldn't have known how, but
Yep.
I have never worked in that realm. But bringing the director in right up front and being part of the team, and he was with us. Eric Feber was his name, and he was with us every step of the way, and knew
Mm,
what we were doing, and then he could disseminate the information out because we had the same goal. The same exact goal was to get pay raises and good benefits for the union. And so that was the strategy. I didn't come
genius.
up with it, but it was ingenious that,
That it really is. It's so important because ultimately you have the same goal,
yeah,
right? A union leader wants the best quality healthcare for his members, her members, and at the lowest cost. Because let's face it, if the employer or the organization uh, that is employing the union members is saving money here, it leaves it leaves money that can flow into the pockets of those union members, in addition to many ways that those funds can be appropriated.
right.
But one of the things that I always advocate for as a consultant when I am dealing with an employer or an organization is at least have a plan to take a portion of the savings and give it back to your people, because when they have skin in the game, when they are pulling with you and there's something in it for them, boy, it really greases the wheels. It makes things a lot smoother, and everybody kind of knows that. I think you could almost ask a kid on the street, how, what, what's your healthcare like, Mister? I don't know anything, but what are you talking? Get away from me, you creep! No, but you could even ask a young person, like, what is healthcare like? And so many of our young people are having negative experiences. Like you know it in your bones. Like there's
Mhm.
just something wrong here, and we could do better. Boy, did you do better! So
But I like your strategy there. That was really, really excellent. And our leadership did that for us.
wonderful. Yeah, it's so important because at the end of the day, it shouldn't be a contentious relationship.
No.
Whether it's union and management or employee employer, employees are the lifeblood of any organization.
Mhm.
You gotta treat them well, and you got to take care of them. And if they're feeling unappreciated, and it's all about the people in the ivory tower, things aren't going to end well.
No, they really aren't. And you're
Yeah.
talking about their health
Yes.
and their family's health. Um, yeah.
Exactly. Exactly. Anything else you wanted to touch on or talk about today?
No, I think I congratulate you on what you're doing. You're hanging in there. You're doing great work, and it's hard. And I thank you so much for this opportunity. Thank you.
No, my pleasure, Marilyn. I would tell people where to find you, but you're retired, so you don't want
Yeah.
anybody. You don't want
hmm
anybody talking to
No, I'm in Montana in my little cabin here.
you. There's something very appealing about that. I've been a native New Yorker my whole life, and I love New York. I live in New York City, Long Island. I wouldn't trade it for anything, but Montana sounds like it has its appeal. Might be a little
It
cold
does.
right now, though. It's
Yeah,
11
it
degrees
is real
here in New
cold.
York City, so yeah, it's pretty chilly out there. All right, folks. Well, hey, thank you for joining us on another episode of Broken Healthcare. Until next time, peace and love always. Take care, folks.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.